Hi everyone, it's noon, so I'm going to go ahead and get started. Thank you so much for joining. My name is Jory Fleischer. I am a movement disorders neurologist and assistant professor of neurological sciences here at Rush University in Chicago. And I'm sorry I can't be there physically in person with you, but today we will be talking about improving patient outcomes in progressive supranuclear palsy, or PSP, and evaluating the clinical implications of emerging advances for early diagnosis and intervention. So this is the steering committee. I'm pleased to work with my colleague, Katie Campolidi and Nina Browner, and Dr. Irene Lipan as part of this as well. Here are our disclosures and support. And here are our learning objectives for today. So after participating today, hopefully you will be able to recognize the burden of cognitive, behavioral, and emotional changes as they relate to the progression of PSP, evaluate the current criteria for the diagnosis of PSP, describe the tauopathy and why we care about tauopathy versus synuclein and other things as far as that relates to PSP disease progression, and the clinical efficacy of emerging targeted therapies at addressing this pathology. And then we'll talk about exploring current therapies for the symptomatic management of PSP and their related impact on patient quality of life. So I thought, as any good movement disorders video presentation should, we should start with a video. So this is a 58-year-old right-handed gentleman with a tremor in his left hand for the last 3 years. In the last year, he's noticed that now this has begun to involve his jaw. He was previously completely healthy, no comorbidities, no medications, no past head trauma. He's not been exposed to any antipsychotic medications. He's a non-smoker and lives with his wife and 2 children. Let's see if this video works. All right. So if you're watching, here's his jaw tremor that's been present for the last year. We'll get a closer view. And if you notice, he's not blinking too frequently. I'm going to keep an eye on. He's being asked to stick his tongue out. There's no problem keeping it protruded. And then he'll put it back in. And there's that tremor that comes right back out as soon as he's back at rest. Let's take a look at his hand. So clearly pretty asymmetric. That right side maybe tremors a little bit, but it's kind of more reverberated from the rest of his body. It's really that left side that's going when he's at rest. So here we're asking him to pronate and supinate. You can see that resting tremor persists most of the time. Let's see, just watching him walk. He walks pretty well. His gait is pretty normal. Mostly what jumps out at us is that resting tremor comes back out. So what did we notice? We noticed his masked face, the tremor at rest when holding them out and when walking. Grossly, his gait is pretty normal. And so we would probably lump him into the category of Parkinsonism. And when we say Parkinsonism, what do we mean by that? So we got to take a trip in the time machine back to 1817. This is Dr. James Parkinson. So he was the first to really describe what we now consider to be Parkinsonism. So he described pretty astutely, based on really an observation of only 6 people, involuntary tremulous motion with lessened muscular power in parts not in action, even when supported, this propensity to bend the trunk forwards, and to pass from a walking to a running pace, what we would call festination now. So, and then jumping ahead a couple of years to Charcot, who really put together the cardinal features of what we now think about as Parkinsonism. So tremor, and particularly described this pill rolling tremor of the fingers, pronation, supination of the hands, rigidity or an increase in muscle tone that's not voluntary, akinesia or bradykinesia, which means both movements that are slow but also that decrement as they go on, and then postural instability or trouble with balance and gait. So we think about this as trap or being trapped in the body, Parkinsonism. No slide presentation would be complete without some photos of Lewy bodies. So there we go. In 1912, Dr. Lewy, who was working in Dr. Alzheimer's lab at the time, described these Lewy bodies, what would become known as Lewy bodies. And those are going to be critical in distinguishing Parkinson's disease from Parkinsonism. So when people get sent to movement disorders, often when they get sent to a neurologist with a tremor, the concern is this Parkinson's disease or not? And I always talk with our patients about we need to take a step back first and think about, are you even in the box of Parkinsonism? So this is my Parkinsonism box, inside of which is an ugly Venn diagram. So what is typical of idiopathic Parkinson's disease, which is going to be by far the most common thing in this box, in the Venn diagram? So, and these cardinal features are based on the Parkinson's disease rating scale and the Parkinson's disease diagnostic criteria. So the cardinal features are bradykinesia, or slowness of movement with decrement. You have to have that. And then one or more of the following, either rigidity, tremor, usually at rest, or postural instability. And there are several features that help sort of build evidence to say that someone is indeed showing features of Parkinson's disease rather than Parkinsonism, one of the atypical conditions. So having unilateral onset, remaining asymmetric as the disease goes on, levodopa responsiveness, particularly having symptoms that are responsive to levodopa for at least 5 years. Levodopa-induced dyskinesias are supportive of Parkinson's disease, and a clinical course of 10 years or more. Obviously, we can't know that at the very beginning when someone presents to us, but retrospectively, it's nice to have clarity. We can also build our confidence by looking at premotor features. So someone who has olfactory loss, that's frequent as a premotor symptom of Parkinson's disease, REM sleep behavior disorder or dream enactment, and constipation. And while these are premotor features of Parkinsonism, but not specific for just Parkinson's disease, and we'll get into that. So I think before we talk about the atypicals, here are some pearls maybe for reasons people get sent as atypical Parkinsonism that actually are not too atypical. So 30% of people with straightforward idiopathic Parkinson's disease never have a resting tremor. And those who have a resting tremor do not necessarily respond to levodopa in terms of their tremor. The rigidity may improve, the bradykinesia may improve, but the tremor can be sticky to treat with levodopa. So just because the person doesn't have a tremor, or just because that tremor does not respond to levodopa, does not mean that that person has atypical Parkinsonism. So then, what does? So going through this Venn diagram, if a person is presenting with an early decline in cognition, and especially with fluctuating cognitive performance, we think about dementia with Lewy bodies. Also, if they're having early recurrent complex visual hallucinations early in the course of the disease, the first few years, that should make you think about dementia with Lewy bodies or DLB. And falls within the first 3 years are also common for people with DLB. Moving on, so early dysautonomia. While urinary incontinence and erectile dysfunction, constipation, and orthostatic hypotension can all be parts of Parkinson's disease, when we see these early, when we see these as sort of the primary presenting symptoms, or really the most bothersome symptoms early in the course of the disease, that makes us think of someone having more of an autonomic flavor and perhaps being in the category of multiple system atrophy or MSA. These individuals can have cerebellar involvement, so they may present with gait or limb ataxia and dysarthria, and they too can have falls within the first 3 years of symptoms. And that, again, the falls early is not specific to one of the atypical Parkinsonisms, but it's suggestive of something besides regular Parkinson's disease. And apraxia, especially in combination with some of the other things, or alien limb phenomenon, where there's a limb that's just kind of levitating, not doing anything in particular, or cortical sensory changes. Those are suggestive of corticobasal syndrome. Finally, in individuals who've had prolonged or contemporaneous exposure to dopamine receptor blocking agents, we want to think about a drug-induced Parkinsonism. And in people with vascular risk factors or sudden stepwise declines in their motor function or cognition, we want to think about vascular Parkinsonism. So what does that leave us with? What hasn't been highlighted yet is levodopa-resistant akinetic rigid syndrome, vertical supranuclear gaze palsy. Again, this idea of falls within the first 3 years of symptoms being a red flag, and a pseudobulbar affect. We'll talk about all of these, but these are all symptoms that should be suggestive of progressive supranuclear palsy, at least considering it in your differential. So let's get to another video. Here's a 75-year-old lady who's presenting with 3 years of falling. Her Her first fall occurred while she was going down the stairs. And now she's falling mostly when she's backing up. She has multiple visual complaints. She's had her prescription corrected. She's seen an optometrist, she's seen an ophthalmologist, but she continues to complain of poor vision, especially when looking down. So here we go. Zoom in on her eyes for a second. So hard to tell. She has a haircut that's helping her out here, but she has, you can tell a little bit that there's some hyperactivation of the frontalis muscles, maybe some hypertrophy of these eyebrow muscles, the procerus muscles, which is a procerus sign. It's a little bit hard to tell from this angle, but her head is tipped back a little bit. She has a bit of retrocollis. And now, as we're looking at her smooth pursuits, these are not normal, right? So they're slow. And here, as she's being asked to track vertically, the vertical movement is much more impaired compared with the horizontal movement. And if we take a look, I believe her saccades, this is showing us that actually, as far as doll's eyes, her eyes can move in all of the directions, just not voluntarily. So this is a really good demonstration of a supranuclear gaze palsy. Sorry for the noise. We're right by the pink line. There we go. And if we watch her tapping, so her appendicular movements are not terribly slow. She doesn't have a tremendous amount of bradykinesia compared to how sort of abnormal those eye movements and that facial expression is. And now as she stands up, she needs help to get up out of the chair. She's tentative as she first starts to walk. And we see that there's some freezing of gait, there's some start hesitation. She really has marked difficulty with her walking. And there as she turns, quite unsteady, and you can imagine how she's falling frequently. And here, testing for balance, doing our standard pull test, you can watch, she's even sort of retropulsing. She's kind of pushing herself backwards spontaneously before she's even tugged backwards, and has a really hard time catching herself. So what did we notice? Relatively preserved horizontal pursuit with abnormal horizontal saccades, impaired vertical pursuit and saccades, but these could be partially overcome by the doll's eye maneuver. Relatively preserved upper extremity function we saw with her tapping. She's maneuvering quite well, but very impaired gait. So when we think about PSP, some think of this as the best mimicker of Parkinson's disease. What do these words mean? Progressive. It's indicating that the disease worsens. Supranuclear refers to above the nucleus, and palsy. So really is meant to refer to the eye movements. And the early presenting signs can be blurred or double vision, often leading people to get multiple prescriptions for their glasses. They try different readers, but this can also present with poor driving ability, slowness of movement, poor balance, early falls backwards, and changes in the voice, often with hoarseness, some slurred speech, sometimes a bit of a nasal component to the speech as well. So comparing PD versus PSP kind of side by side, when we think about the mean age of onset, typically we think about Parkinson's in folks over the age of 60, although not exclusively. And PSP can start earlier than that. So it can be closer to 50s to 60s as far as onset. The posture differences can be quite striking. So in our folks with Parkinson's disease, they're much more often flexed forwards, whereas our folks with PSP, the posture changes are early, and they're often more upright with their neck going backwards. So as opposed to a waiting room full of people hunched over and stooped downwards with Parkinson's disease, it's that PSP person who's sitting there and is, eyes open, often with this really surprised facial expression and tilted back. Falls in Parkinson's disease tend to be later in the course of the disease, and people are falling forwards, which you can imagine watching this image of this person tipped forward. Their center of gravity is somewhere out here in front of them, right? But in someone with PSP, they tend to fall early. They tend to fall backwards, and especially that retropulsion, getting up out of a chair or sitting back down into a chair and almost colliding with the wall behind them. Eye movements in Parkinson's disease tend to be normal or relatively normal, whereas it really is a hallmark of PSP that they have this vertical gaze palsy in addition to other problems. In Parkinson's disease, most people have a good response to levodopa. It depends on what symptoms we're treating. But in PSP, they may initially have a good response, but that may evolve over time. And then a major difference is in mean survival. So people with Parkinson's disease can survive 10 to 15 years, if not many, many more than that, whereas the mean survival in PSP is quite often shorter, so 6 to 10 years. And we'll get into the abnormal protein, but PD is sort of the hallmark synucleinopathy, whereas PSP is a tauopathy. So in terms of epidemiology, Parkinson's disease affects over about approximately 1 million people in the United States. These numbers are US specific. PSP, our numbers are not quite as good. There aren't as many studies, but we estimate approximately 20,000 cases of PSP and then declining from there. MSA is sort of second to PSP, and cortical basal degeneration or cortical basal syndrome is probably the rarest. These are all considered the Parkinsonism plus syndromes. And so what do the terms tauopathy or synucleinopathy mean? They're fairly straightforward. So tauopathy are diseases happening due to problems with tau. So most often we think about Alzheimer's disease. Frontotemporal dementia is also a tauopathy. But in the Parkinsonism, Parkinson's plus world, we're talking about PSP and CBD, cortical basal degeneration, cortical basal syndrome. Synucleinopathies are due to abnormal accumulations of alpha-synuclein, and that really gets at Parkinson's disease as the hallmark, multiple system atrophy or MSA, and Lewy body dementia. So thinking about these abnormal protein accumulations, here is that Lewy body, and this is really an accumulation of misfolded alpha-synuclein within the cell. In dementia with Lewy bodies, rather than seeing it in specific areas of the brain, that sort of follows the Braak hypothesis and a stage trajectory. In Parkinson's disease, in dementia with Lewy bodies, we see Lewy bodies throughout the cortex, throughout the brain, sort of in a more widespread pattern. In PSP, here's the hallmark pathology, these thorny astrocytes. And in CBD, we see astrocytic plaques. So again, focusing on PSP, we see these tuft-shaped astrocytes, which are really composed of 4 repeat tau aggregates. So when we think about the motor symptoms of PSP, we think about Parkinsonism, slowness of movements, rigidity, multiple falls, and near falls. We think about dystonia, so abnormal tone of the muscles, particularly in the neck, often with that retrocollis, but sometimes can be anterocollis. But these can really lead to head injury and fractures with these falls. In terms of their non-motor symptoms, the blurred vision, the inability to look down, swallowing problems, poor executive function, impulsivity, lack of fear of falls. So this can be very different from our Parkinson's folks, is that our folks with PSP can have impulsivity. So even though they are at high risk of falls and they may fall frequently throughout the day, when the urge hits them to suddenly get up out of the chair, they just get up and fall straight forward or fall straight back. They have problems with speech and communication. And so these can lead to pneumonia, to choking, and all kinds of complications. So what are the diagnostic criteria for PSP? And these are recently revised. So in order to begin approaching this, and we will go through all of the nitty-gritty of the diagnostic criteria, I think that's more for a movement disorders consult. But really what I want you to take away from this is what are we looking for? What are the types of things that we're looking for, so that if you see any of these things, PSP pops up in your mind as a differential and you think about referring patients on to the neurologist or the movement disorders neurologist. So to make a diagnosis, this should be sporadic in occurrence. This does not tend to be hereditary. Patients should be at least 40 years of age or older, and there should be gradual onset and progression of these symptoms. They should not be sudden. We don't see predominant episodic memory impairment that would push someone more towards thinking about Alzheimer's, or predominant autonomic failure. Typically, we do not see visual hallucinations or cognitive fluctuations. That's more DLB, or dementia with Lewy bodies. We don't tend to see predominant unexplained multisegmental upper and lower motor neuron signs that would push us more towards motor neuron disease. Sudden onset, stepwise, or rapid progression would be more concerning for drug-induced or infectious or paraneoplastic or autoimmune. Prominent ataxia, again, could be MSA or other things, or other identifiable causes of postural instability. What we're looking for to start to get to a diagnosis of PSP is ocular motor dysfunction, postural instability, akinesia, cognitive dysfunction. And the way that these are laid out with the most recent diagnostic criteria published in 2017 by the Movement Disorder Society. So in each of these four categories, ocular motor dysfunction, postural instability, akinesia, and cognitive dysfunction, there are essentially three different levels of certainty. And so if you have criteria, if your patient meets criteria at this level one, at the highest level, you could be more sure. These are more probable versus possible PSP. And there's sort of, you can imagine there are different combinations. So you could have vertical supranuclear gaze palsy, but maybe the postural instability is less so. Or the Parkinsonism is suggestive, but it's not clear cut. So there's any number of ways that people can be sort of choosing from column A through D and from rows 1 through 3. But these are the things that we want to look at. So if someone is coming in and has clear vertical supranuclear gaze palsy, you're going to be much more certain than if you see the occasional square wave jerks or some eyelid opening apraxia. Those are suggestive, but they're not slam dunks. Additional clinical clues, so levodopa resistance, meaning you have to try them on levodopa, hypokinetic spastic dysarthria, dysphagia, and photophobia. And then imaging findings, which I'll show you in a moment, but predominant midbrain atrophy or hypometabolism or abnormalities on a DAT scan. So what does that look like? Well, in the normal section, we can see here's a normal midbrain, a normal pons, right? But in this individual with PSP, we see the classic hummingbird sign. So prominent atrophy of the midbrain with a normal sized pons in relation. So this is, if you squint, it could be a hummingbird. And also this idea of a Mickey Mouse sign, which I think is always even more subjective than that, but again related to that midbrain atrophy. So here's PSP, and here's normal, and there's poor Mickey Mouse. So what do we do with our folks with PSP? I think before getting into anything, it's really important to know that even though this is a life-limiting condition, there is so much that we can do to improve quality of life for these patients. Pharmacologic management, but also non-pharmacologic management, education, and support for the patient and for the caregivers. Knowing that there is a name for what they're going through and knowing that there is support for what they're going through goes a tremendous distance for these patients. So there's really a comprehensive care continuum. These individuals often have insidious start of their symptoms. They get diagnosed. Many people with PSP will be misdiagnosed with Parkinson's disease at first because the Parkinson's symptoms may be more obvious than the eye movement abnormalities or some of the other things, which can come along later. We think about symptomatic treatment, medications, but also PT, OT, and speech, which we'll get into. But I would argue advanced care directives and thinking about what matters most to the patient, that should be early. This should be thinking about this as we're making the diagnosis and revisiting it all the way through. Similarly, building a village of support, building that care continuum and a team for that patient and care partner, all the way on through palliative care and hospice. So what do we have now? Well, still to date, the best thing that we have is carbidopa-levodopa. This leads to a transient or small benefit that's been suggested in small retrospective reports. And the best practices at this time are essentially that we try levodopa and we push it. We push it to higher doses that we might consider in someone with, more recent diagnosis of Parkinson's disease, because it may take a higher dose to see improvement, and we may see transient improvement for some amount of time, months, maybe years, before those minimal benefits tend to disappear. They can have adverse effects. They don't tend to have dyskinesias. That's less of a worry, but they may feel more nausea. They just may not respond, sort of only get these side effects and not the benefits. Sometimes we will try amantadine as a second line. There's some evidence that there may be some infrequent and transient benefit for gait and for freezing of gait. The studies that have looked at dopamine agonists in patients with PSP has not shown any efficacy, so we do not tend to use those. They tend to get the side effects and no benefits. What about other medications? So there's interesting evidence in Parkinson's that acetylcholinesterase inhibitors such as donepezil can show not only some modest effect for cognition, but also potentially for mobility. In some small studies in PSP, there's some modest effect in cognition, but questionable benefit to mobility versus worsening. It's certainly worth a try in many patients as long as they understand sort of risks and benefits. Also, there's been small studies looking at ECT, which has shown in a small group some motor improvement, but significant confusion, particularly in this group of patients that's prone to cognitive decline already. We can use Botox or botulinum toxin quite effectively, useful for apraxia of eyelid opening, which can be really functionally limiting for these patients, and for sialorrhea, not just as a sort of stigma producing sialorrhea, but really involving swallowing and impacting their risk of aspiration. Antidepressants can be very helpful, and medications to treat bowel and bladder problems. So no, we do not have something directly for PSP right now, but do we have symptomatic treatments for many of the motor and non-motor symptoms that they have? Absolutely, similar to Parkinson's disease, and we should be using them. That's a great question. I see someone asked about pimavanserin use. I have not had substantial experience using pimavanserin in this patient population. I'm hesitant to do so. I have not seen any data supporting it yet. And unfortunately, the data for an anecdotal experience for a lot of people in PDD, PD dementia, and dementia with Lewy bodies is often we use it for people with hallucinations, which doesn't tend to be an issue in PSP. But if they had that, I would be concerned because oftentimes we see a worsening transiently before we see any benefit. So that can be a concern. So if we don't have great therapies, if we have levodopa and some of those other things that I mentioned, what else can we do? Actually, a lot for these patients. And I would argue that, while we rely on our pharmacology, we should be relying on physiotherapy and our occupational therapy colleagues even more so, particularly in these patients. Our PTs and OTs can do a tremendous amount. And while everyone is socially distant right now, our practice, and certainly almost everyone has switched over to telemedicine. And as someone who has been doing a lot of work with home visits for years, there is nothing equivalent to being able to look at someone's home and see exactly where they're falling and having another set of eyes to say, if that's where you're falling, you could put a grab bar there. You could be using a shower stool. You could be using something else to help. So do not underestimate the power of PT and OT interventions to help with particularly these patients. So even things like a heel wedge on the inside or outside of a shoe to shift that weight more anteriorly. Instead of patients tilting backwards, can you help them lean forwards a bit more? Things like a lightweight walker are typically dangerous for those patients because they will tip backwards and the walker will go with them. But a more heavier weighted walker, especially something that has weight towards the front, like a U-step, or people have often kind of jerry-rigged their own front-loaded walkers, those can be really helpful. So thinking about the motor symptoms, this is just a summary table. Pharmacologic approach is really levodopa and pushing it to higher doses than you might feel comfortable with early on in someone with straightforward Parkinson's disease, but involving our PT and OT colleagues early and often. Motorized wheelchairs can be helpful. And then for dystonia, thinking about amantadine, baclofen, I tend to find has more cognitive side effects and sedating side effects than benefits for patients. And sometimes our OT colleagues can find non-pharmacological approaches to help or to prevent contractures. So when we think about the non-motor symptoms of PSP, and I took this paper, this figure from a paper, but it's focused on Parkinson's disease, but I think this is all the more true for PSP, is this is really an invisible population. And I mean that in terms of clinical care, that these patients, because of their disease severity and how quickly the disease progresses, they essentially present to clinic if they do, and then they're lost to follow-up. And it's not for lack of wanting to be seen, it's because it becomes so difficult to physically get to the clinic for that patient, for their care partner, that they kind of fall off the face of this curve. They fall out of reach of the clinicians right when they're needed the most. And they're really unseen in research. If you can't present for an outpatient clinic visit, you can't be recruited to clinical trials, right? And so there's very little out there, especially when we think about the more advanced folks and especially homebound individuals. This was a study by Buki and colleagues that looked at actually 38 individuals with PSP and corticobasal syndrome who were admitted, and wouldn't this be lovely if we had this here, but to a palliative care inpatient unit where individuals with PSP and CBD were admitted, and they looked at what were the admitting criteria, what were the reasons for admission, and what improved. And so they actually found swallowing difficulties, gait instability, spasticity and pain, impaired communication, cognitive mood disturbances, and respiratory symptoms were among the most common reasons. And many of these were treatable. So, what does it take? It really takes interdisciplinary care. It takes building a team so that you, as the primary care doctor or the neurologist or the nurse, you should not be the only person expected to take care of these patients. They are complex, they have complex needs. You have complex needs to take care of them and to address all of these things. So, not only the neurologist and the nurse and all of these folks listed, but urology, gastroenterology, dentistry, geriatricians are all really valuable members of the team, and I'm certain that I'm leaving off many. I've already mentioned the value of PT and OT, but especially thinking about swallowing. Swallowing can be so challenging for these patients, and helping them with breathing exercises, manual techniques to prevent chest infections, simple things. Occupational therapists can help with raising the height of a plate so it's closer for patients, using rocker knives and food guards, deep spoons, or sporks. Sometimes can be helpful putting a silicone mat under the plate just so it doesn't slide around on the patient. Really simple things, a lot of easy life hacks that people can buy on Amazon, even during social distancing, that can be tremendously helpful. And then our speech therapists, especially for PSP patients, should be involved early, should be involved often. Ask these patients to have booster sessions with speech therapy because there is a lot that can be done throughout the disease course. From anticipatory guidance, what could come down the pike and teaching people how to eat and drink in the right positions, helping guide caregivers because as the disease progresses, the impulsivity can often lead patients to know that they should take small bites, but yet grab giant chunks of meat or a big piece of dry bread, even though they've been told many times not to do that. It's that the interplay between what they can swallow and the impulsivity sort of superseding that. And then communication. There are a number of things that can be done, again, early as anticipatory, as prehabilitation, when a diagnosis is made, that can really set patients up to do better and to stay connected. Because as communication declines, these patients tend to really withdraw and they can often appear cognitively impaired even when they're not, just because it's so hard for them to communicate and it may be so hard to keep up in conversation that they really become socially withdrawn. So emphasizing loudness, not just to the patient, but reminding the family that it's okay to ask the person to speak up. There are a number of assistive communication devices out there that can be used throughout the entire journey of PSP. I think something interesting to consider, which has been looked at in motor neuron disease and other conditions, is voice banking. So making the plan well ahead of time to say, you may lose the ability to speak, but there are different apps, there are different services that can help that patient essentially to read off a list of many, many, many phrases and words so that if the time comes when they cannot get their voice out, they can use an app, and instead of being a computer generated voice and sound like Siri or Alexa, it sounds like them because it's their voice. So reminding them to speak slowly, allowing ample time for them to respond, keeping sentences and comments and questions short, and pausing. And then really trying to tackle one topic at a time, training those caregivers and reducing background noise. It can be so difficult for a patient to try to get the words out that trying to shout over a crowd is really challenging. Vision difficulties. I can't emphasize enough how valuable our neuro-ophthalmology colleagues and ophthalmology colleagues can be. There are a number of eye movement exercises that people can do, scanning the environment before walking, tilting their head to assist looking down. Prism glasses can be incredibly valuable. And then treating dry eyes, which can be a complication, treating blepharospasm, treating eyelid opening apraxia. There are a number of different things which are manageable and can really go a long way towards improving quality of life for these patients. So I mentioned some of these. This is just a summary. So let's talk briefly about sleep. Sleep disturbance is really common in patients with PSP and probably more so than in patients with Parkinson's. They have decreased total sleep time, they have decreased REM sleep, increased frequency and length of nighttime awakenings. And REM behavior disorder, though less common than in Parkinson's, is certainly seen in PSP, as is obstructive sleep apnea and periodic limb movements. And all of these are treatable, manageable. But frequently the basics of sleep hygiene. Things that we all know that we should do, that we probably are not doing during this time of COVID, but that we should be doing ourselves and reminding our patients. Simple things like avoiding caffeine, alcohol, and nicotine later on during the day, limiting liquids in the evening, increasing activity level during the day so that they are more tired and able to sleep, limiting naps during the day, and maintaining that regular sleep-wake pattern, especially right now as people are staying home. It's not okay to sleep in until 10 and 11 and noon and to go to bed at midnight and 1 and 2, because that's going to be very difficult to switch back. Now, thinking about depression, so 40 to 100% of patients with PSP, depending on the studies, will endorse significant depression. And those are rates that are higher than in patients seen with Parkinson's disease. And in studies in Parkinson's disease, depression is the #1 predictor of quality of life. So we really need to take this seriously in our individuals with PSP. We need to be screening for it and we need to be treating it. So there are non-medication treatments, including social involvement, support groups, exercise, cognitive behavioral therapy. These are all very powerful. But for many individuals, if they have engaged in those things for at least 12 weeks and have not seen progress, this is a chemical imbalance, just like the motor symptoms that we see. And so we should be treating this aggressively because it can really limit their quality of life. So SSRIs tend to be well tolerated. We tend to shy away from tricyclics because although they can be effective, their side effect burden tends to outweigh the benefits. And then while there are other antidepressants, things like mirtazapine and others, they can have both sleep and depression benefits in other populations. They have not been studied extensively in people with PSP. I want to touch briefly on pseudobulbar affect, also called emotional lability or emotional incontinence. This is individuals who are laughing or crying at things that wouldn't have typically led to such dramatic responses in the past. And this is particularly common in people with PSP, and it can respond to antidepressant medications or a combination of dextromethorphan and quinidine. We think about Parkinson's and the guts. There's been a lot of interest in the microbiome and constipation in Parkinson's. Actually, in studies, more than 85% of people with PSP complain of GI issues. So there are the standard things to recommend to people: healthy, well-balanced diet, staying very well hydrated. There is no evidence as of yet for dopamine-rich diets. It's just not absorbed. Nutritional supplements, there is nothing promising thus far that has reliable evidence. A daily multivitamin plus calcium should be more than enough for most people. But what are the common concerns? #1 is weight loss. So we frequently see sort of the dwindles, the failure to thrive. Sometimes this is due to nausea, sometimes this is depression, sometimes this is loss of appetite or decreased movement. And in people with PSP, frequently they have that dysphagia, they have difficulty swallowing. They may have more apathy, just sort of a loss of desire to eat. You can put the food in front of them and they just don't take very much. But this can have really dire consequences. So if it's an issue of nausea, adjusting medications. If they are depressed, screening for and treating the depression is important. But then addressing with a nutritionist, with a dietitian, ways that you can improve their nutrition, get them to eat. And if that's small, more frequent meals throughout the day, great. If that is taking a nutritional supplement shake, that's fine. For many people, having one of those canned drinks is okay for a few days, but gets old very quickly. I encourage patients to think about those as an ingredient and not the end product. Throw it in a blender, throw it in a food processor, use it as an ingredient for a better milkshake or smoothie, and get those calories in. Bone thinning is a big concern, so we want to be screening those patients and encouraging them to walk, to use weight-bearing exercises, weight training exercises, and to get their calcium. Dry mouth and tooth decay are big problems, and PSP medications and non-PSP medications can contribute to lightheadedness, fainting, dry mouth, dental problems. So we want to make sure our patients are staying extra hydrated, availing themselves of the various sort of dry mouth over-the-counter treatments that are available, and seeing their dentist, because if they have undiagnosed dental issues, if they have abscesses, if they're in pain, that's relatively easy to fix thing that we can address in terms of their weight loss and their risks of infection, hospitalization. Constipation is a big issue. We want to prevent it first with adequate hydration, fiber, and getting people moving so that we can treat it second. There are a number of things out there, and for the sake of time, I won't go into these in detail, but things like Senna, Docusate, Colace, while these can be helpful in the short term, many patients develop tachyphylaxis to these. So better alternatives would be things like polyethylene glycol or Miralax. Those are not absorbed. People do not get tachyphylaxis to those, so we can use those for longer. But also various different recipes that are out there to help people sort of incorporate hydration and fiber into their daily diet. And then thinking about the unmet clinical needs, it should be clear that while we do have things to offer our patients, we don't have everything. And we certainly need better things in all of these categories. So number one, we need disease-modifying therapies. We also need more effective symptomatic treatments for everything that I've mentioned. So thinking about PSP as a tauopathy and emerging targeted therapies, what's out there? Well, how do we get to things that are out there? As you may well know, and as is so frustrating to our patients, they hear about a lot of research happening and yet they don't see anything coming to fruition for them. And that's because, it can take years and decades to get from a promising potential compound in the basic research lab all the way through to clinical trials and to an FDA-approved medication. So what are some recent clinical trials? What are some things that have been studied for PSP? Unfortunately, none of these thus far have shown benefit. So people have looked at repetitive TMS or transcranial magnetic stimulation, has shown promise in other conditions, but not, unfortunately, for PSP. People have looked at riluzole, typically used in ALS or motor neuron disease. That did not have an effect. Davunitide, which promotes microtubule stability and decreases tau phosphorylation, seems like it should be a good idea, promising in preclinical studies, but had no effect in clinical trials. Tideglisib, which prevents abnormal chemical changes to tau, abnormal phosphorylation, unfortunately did not show a benefit. And zolpidem, common sleeping medication, was studied based on some case studies, and that also did not show a beneficial effect. Things that are ongoing. So there is salsalate, which is a prodrug of salicylate, and in mouse models that inhibits tau acetylation. Seems like it could be promising. There is a 10-patient open label pilot futility trial that was completed, but those results have not yet been published. But again, very small open label and really looking at safety. There is animal models data that shows that young plasma, so giving aged mice young blood plasma, demonstrated some improvements in certain age-related cognitive impairments. Something to keep an eye on, kind of a fascinating idea, but if patients reach out and are asking about getting young plasma, they don't want mouse plasma yet. We are not there in humans. So there's a small phase 1 study underway, but again, very small. There's an ongoing trial looking at rivastigmine for falls, specifically in people with PSP. So this builds on, I mentioned earlier, donepezil and other acetylcholinesterase inhibitors that have been looked at more closely in Parkinson's disease and dementia with Lewy bodies. Those are being pulled in for broader clinical trials in the PSP population. So keep an eye out for those. And then deep brain stimulation. So while we would not typically do deep brain stimulation in the usual locations that we use for Parkinson's in people with PSP, because those will tend to worsen their symptoms. There's studies looking at using the pedunculopontine nucleus, which regulates locomotion, in very small samples of people with PSP. So no fall reduction, some improvement in some gait parameters, but definitely stay tuned. This is an ongoing area of study. I think one thing that's exciting is many of the trials that have looked at the symptomatic therapies that we've had and others have really looked at things sort of downstream in the pathway. But more recently, in the last few years, there has been the advent of anti-tau antibodies, and several different companies have looked at this. Different anti-tau monoclonal antibodies. There was an AbbVie trial that was a randomized double-blind controlled trial that enrolled 378 PSP participants in 8 different countries. Unfortunately, that was stopped this past July when the interim analysis showed no benefit compared with placebo. Going along those lines, another anti-tau monoclonal antibody, this time by Biogen, had a large 490 participant randomized double-blind placebo-controlled trial. That was also stopped in December of 2019 because there was no benefit compared with placebo on the PSP rating scale or on the other biomarkers that were used. Is this reason to give up on this direction of study? I don't think so. There's at least one other anti-tau antibody PSP trial that is planned, and I'm sure others that will come as we, pick ourselves up, retool, and study better ways for target engagement and other opportunities. So this is a great figure from Adam Boxer and colleagues in a Lancet Neurology article in 2017 that really demonstrates the more we understand about tauopathies and PSP in particular, the more we understand the various different targets that could be engaged and modified to try to get a better handle on this disease. And in the meantime, what do we do to support our patients and caregivers? So coping with the diagnosis is really important. I think for many of these patients, as I mentioned earlier, they are frequently diagnosed with Parkinson's disease and often may go to Parkinson's support groups. And this can be educational in some ways, but often what I hear from patients and from caregivers especially is they sit there, they look around the room and they think, here's this guy who says that he's had Parkinson's for 10 years, and yet my loved one who was just diagnosed looks worse. And, why is my loved one having symptoms that this guy is saying come, 5, 10, 15 years later? Something isn't right. This just doesn't fit. So often they go through sort of the trauma of a Parkinson's diagnosis first, only to then feel like this isn't quite right, to search for that diagnosis and then be re-diagnosed again. So there's a lot of stress that goes with this. There's stress from hiding the diagnosis. There's a lot of withdrawal. People can avoid public situations, avoid medical care because of concerns about what this could be. But getting quality information is really important. I put plan the conversation, and that really is plan as the provider how you're going to deliver this diagnosis, and there's a lot of support to do that. And for family to think about how are they going to tell the kids, the grandkids, family members. For many of these patients who can be younger, they may need to disclose the diagnosis to their parents, to their aging parents, and how do they do that? So helping them find resources to do so. And while many people are concerned about disclosing their diagnosis, most people do find support. Largely, there's been publications and interesting things in the lay press about Parkinson's disease, but this is becoming more common to talk about PSP. It's getting greater coverage in the media. And I highlight here this great photo. So this is a sitcom, Zoe's Extraordinary Playlist, that came out, and it is first, to my knowledge, depiction of someone with PSP on a mainstream main network comedy series. So I encourage you to check that out. Peter Gallagher did a lot of research in portraying someone with PSP with great dignity and compassion. And if you need sort of a reminder of what is the face of PSP, he does it better than many people that I've seen. And this is often, if you see someone who looks like this in your waiting room, please, please, please think about PSP. So where can we refer patients for help? So Cure PSP is an outstanding foundation that really helps support research, but helps support patient education, provider education. So curepsp.org can be tremendously helpful for patients, especially to go to if they've been misdiagnosed with Parkinson's first, they're coping with the diagnosis, they will find a lot of things that resonate with them. This also directs them to clinical trials and to resources in their area. For providers, I think this is fantastic. They've created several different brochures, brief sort of PSP, here's some answers. And then if you take a look down here, there's this gray booklet. I order this and we provide this to our patients, not necessarily that it's focused on lay education, but this is something that a patient can take with them when they go see a physical therapist or a speech therapist who may not know about PSP at all. But there's essentially a one-page primer in there about for PT, what do I need to know about PSP? For a speech therapist, what do I need to know? And it directs them further. So you can empower your patients to empower their therapists and their allied health team members. While this is specific to Parkinson's disease from the Parkinson's Foundation, this Aware and Care Kit is essentially a go bag. If people have to get hospitalized, it contains a lot of resources, many of which apply for people with PSP. So patients can go to this website, they can order this for free and have it shipped to them. It's a great way to sort of, if someone needs to be hospitalized, have everything they need at their fingertips and empower the patient to advocate for themselves, especially now in the time of COVID when a care partner may not be with them to do that. I would encourage you to take a look at or direct your patients towards clinicaltrials.gov. As I mentioned, there are a lot of things coming down the pike for people with PSP. And the only way to get new trials, new therapies to the public is through clinical trials and participation. So in summary, we want to think about early falls, extraocular motility changes, dysphagia as presenting signs, or seeing those within the first 3 years of Parkinsonism to really think about PSP. That the Movement Disorder Society PSP Diagnostic Criteria have strong antemortem clinical and pathologic concordance, so they are very useful and they will help identify patients with more rare PSP phenotypes. That's more a matter of sort of combining that column A through column D with level 1 through level 3, but using those can really help guide us. That this is a tauopathy, and to be encouraged and to encourage our patients that there are targeted therapies coming down the pipeline focused on abnormal tau phosphorylation, acetylation, and cell-to-cell spread. That treatment is symptom specific. That for motor symptoms, carbidopa levodopa is still our best pharmacologic option, and to involve our PT and OT colleagues early and often. For dystonia, botulinum toxin injections can be very powerful. For mood, including depression and pseudobulbar affect, to think about our antidepressants. Dysphagia, to get speech and swallow evaluation and therapy early and often. Vision, use our neuro-ophthalmology and ophthalmology colleagues. And that despite the recently failed trials of riluzole, tidegliflozin, davunitide, and the anti-tau antibodies, there are more coming down the pike, and there is reason for hope. And that this is a rare disease, so our patients are even more isolated, especially now in this time of social isolation. I hear from many patients, this isn't anything new to them because they've felt homebound and they've felt isolated because of their symptoms this entire time. So providing resources, information, and access to clinical trials can be tremendously powerful. I want to acknowledge the Biogen for making this possible, and colleagues, Dr. Compoliti, Dr. Browner, Dr. Litvan, the steering committee for this. And so with that, we have some time to take some more questions, and I will encourage you, please go to the link below to complete the post-assessment and evaluation, and I hope that this was helpful. And with that, I will see if I can see some of the questions in the chat. Have we seen greater efficacy in any of the SSRIs for depression or impulsivity? I'm not aware of any clinical trials pointing to one more than the other. So my experience has been going with whichever SSRI I am most comfortable with prescribing and adjusting. So sometimes, some that are more insomnia promoting versus, sort of more wake promoting versus more sleep promoting. It depends a bit on the other symptoms going on for that patient, and trying to keep in mind their comorbidities. See if we can hit two birds with one stone for a lot of patients. Well, thank you all so much for attending. Please don't hesitate to reach out, and the content should be available to review in the future. Thank you all so much, and have a great day. Stay safe, stay healthy.